Okay, so thank you everyone for coming to hear my talk. Today we're going to go over a few things regarding my project, and in doing that, I hope that I will teach you about identifying the knowledge gaps that exist among trainees in the care of young adults with developmental disabilities, and also how to apply a systematic framework to approach young adults with developmental disabilities. So to start, just kind of framing the population, in the United States, about 18% of the population, or 61 million adults, live with some sort of disability, and about 7 million, or 2%, have an intellectual or developmental disability. So when we're talking about developmental disabilities, we're talking about chronic impairments in physical, intellectual, or both domains that do vary in severity and have to present by age 18. And intellectual domain, we're talking about both cognitive and adaptive functioning. And physical, we're talking about motor impairments, things like tetraplegia, spasticity, dyskinesia. And then for both, if we have impairments in intellectual and physical development, we call that a global developmental delay. And some examples of common developmental disabilities are autism, ADHD, cerebral palsy, Down syndrome, and Fragile X. So overall, this population has been growing quite a bit. So in 2016, about 17% of children in the US between the ages of 3 and 17 were diagnosed with a developmental disability. And kind of paralleling that, the life expectancy of these individuals, especially those who have some sort of mild or moderate intellectual disability, has been approaching that of the general population, so around the mid-70s. And the number of adults that are living with intellectual and developmental disabilities age 60 years or older is estimated to double, so to about 1.2 million by the year of 2030. Compared to 2000, it was only about 700,000. So some of the challenges that we actually see with this population as they age involve the support services that they receive when they're children, but then don't often carry over to adulthood. So one example is the support services through schools. So through the Individuals with Disabilities Education Act, all these individuals are entitled to a free and appropriate public education that goes up to 21. But after that, there's no real government-funded education programs that these individuals can attend. And really, it becomes the caregiver's responsibility for coordinating these additional services, and that often puts an extra burden on the caregivers. And there's also difficulty accessing these services in general. So this can lead to development of chronic health conditions that go undiagnosed, and they can actually develop at earlier ages in more severe forms. And the final thing that we think about with this population is the balance of adequate support and independence. So we want to give them autonomy that they deserve, but we also want to do that in a safe way. And when we think about our role as physicians, when we look at it from the pediatric side, typically we think about the responsibility of diagnosing these conditions, managing them, but then when they become of the adolescent age, transitioning them to the appropriate care of adult providers, so internists and subspecialists. However, in pediatrics, we often have minimal training in that transition process itself. And on the internal medicine side, our training programs don't offer any standardized curricula or competencies in the care of individuals with developmental disabilities. And that includes things like assisted decision-making or guardianship. And studies overall just show both sides are very uncomfortable with providing care for patients who have any sort of chronic illness, and this does include developmental disabilities. So there has been a lot of talk about integrating this into medical school education, residency education. So recently, the AAMC had come out with this curricular models for integrating and improving diversity, equity, and inclusion in medical education around July 2022. And within this packet, they basically highlighted developmental disabilities as one of these areas they want to focus on. And they made a really interesting suggestion where using standardized patients who actually have developmental disabilities within curricula would be a good way to integrate practicing communication skills for any sort of medical presentation or clinical area. So just having it more as a standardized thing to hire these patients with developmental disabilities and, basically require students to interact with these patients on a more regular basis. And this also kind of plays into preparing the learners to accommodate their learning environments and their clinical environments for these patients. If they have any sensitivities that have to be addressed, or if they have specific devices that they have to use during the visit, knowing how to incorporate that is really helpful. And then on the pediatric side, there was actually an ACGME update to the entrustable professional activities packet. So they suggested in March of 2021 that we include transitions of care, including that to adult providers within our competencies. So you can see here, this is from that ACGME milestones packet, and it's right here. So having all of this in mind and knowing that there's a lot of gaps in what our learners know and how comfortable they are, I decided to make a curriculum that would address this and at least introduce our residents to the core topics and the core issues that come up when dealing with this population. So the curriculum I designed, I wanted to be kind of respectful of our learners' times and integrated into something that would have a spot already. So we use the ambulatory didactic time for both pediatric and internal medicine residents. And we had a 1-hour slot where we made an interactive workshop that included didactics, 2 clinical cases, and a role-playing opportunity to help delve into the specific issues of transitions of care and decision-making for adolescents and young adults with developmental disabilities. So this actually encompassed PGY 1 to 3 internal medicine residents, PEDS residents, and combined med PEDS residents. And the way that we actually present the curriculum, we review the definitions of developmental disabilities and kind of list examples to make sure learners start with the same knowledge base. We also discuss levels of different intellectual ability and help them try to apply that to clinical cases. We teach then a structured framework to approach any patient who has a developmental disability. And then we together work through 2 clinical cases to highlight the challenges that come out when you deal with transitions of care and decision-making. So this is kind of an example of the way our workshop looks in terms of a timeline. So each session actually starts and ends with a questionnaire, and the questionnaire will go over knowledge areas and comfort areas for these individuals when dealing with our patients who have developmental disabilities. And once we start the workshop, we have 4 key areas that we talked about already. So the definitions are systematic approach, and then 2 cases that cover our key topics. And then after we do our questionnaire to close the session, we also have 2 follow-up time points of the questionnaire, 2 months later and 6 months later, to see how the residents retain the knowledge and if they're able to actually apply it to a clinical case. And the primary outcomes that we measured in assessing the curriculum was the change in residents' overall knowledge in their care of individuals who have developmental disabilities immediately after, and then 6 months after the workshop. So just to show you a bit of our curriculum content at a closer view, the systematic approach that we teach our learners to apply when they're dealing with our patients is this 3-tiered model. So we tell them to just kind of start thinking about the patient in terms of where their level of function is. So when we say that, we mean looking at their chronological age, but then understanding how that departs from their developmental age. So in that portion of the curriculum, we bring up the idea of looking at intellectual ability in terms of adaptive functioning. So what someone can do on a daily basis for themselves in terms of activities of daily living, but also thinking about their cognitive function. So if there's any IQ testing available, how that would play into it. And also, if you don't have that available, how you can do a quick kind of on-the-spot assessment talking to the patient. Then we go into the legal considerations that come into play when someone turns 18. So we discuss kind of the fact that at 18, we assume someone can make decisions for themselves independently unless proven otherwise. So some of those cases will include people with more severe intellectual disabilities that aren't able to attend to their activities of daily living, or if they need extensive assistance in terms of finances or just doing everyday tasks. So we get into the idea of guardianship versus supported decision-making and what those models look like. And then finally, we encourage the learners to think about the specific needs that these patients would have. So we tell them to think about the primary care needs as they would for any other patient, because they should be getting all those same screenings, but also understanding how you have to adapt all those screenings to the patient because of their specific needs. So if they have sensory sensitivities, or if they have a cognitive disability and they need something to be explained to them a different way, we tell them how to approach that. And it's the same with the specialty care, because these patients often have multiple specialists, and we encourage the learners to try to understand where all this information is coming from and how to build a comprehensive summary. So then our decision-making part of the curriculum, we teach this model of thinking about decision-making for our adults with developmental disabilities. So it's really a spectrum that goes on the left from the most restricted guardianship to the right, which is the least restrictive shared decision-making. And if we start with the least restrictive, that's really the model that we use with all of our patients. So shared decision-making is where the clinician will just help the patient understand a decision that has to be made and let them make it themselves. And they'll provide any resources that are needed, but the patient is really independently doing that with the physician. And then in the middle, we have something called supported decision-making. So this is a model where a patient can actually choose a trusted caregiver or person in their life to help them make decisions. So that person would then get access to the medical records of the patient, and they can help the patient interpret and communicate their decision. So if someone is nonverbal and they need assistance communicating their decisions, or if they have some sort of mild cognitive delay where they might need explaining in a different way or in different formats, that person can help facilitate it. But they're not making the final decision. It's still the patient that is vocalizing their decision. And then finally, the left is guardianship. That's our most restrictive model, where we actually appoint a legal guardian through the court that will make all decisions for the patient. So as you can imagine, that's a more restrictive way for the patient to have decisions made for them. And often the patients are ones that have a lot of difficulty in daily life. So people with more severe intellectual disabilities, or are unable to kind of do any of their daily living tasks. So we really reserve that for individuals who really need extensive assistance. And we try to discourage people from using that as the first reflex if there may be a more appropriate and less restrictive model. And then we get into the idea of how do you even assess someone's intellectual ability. We really encourage the learners to start with a capacity assessment. So I'm going to go over that model that we teach in the next slide. But if there is more information available and you speak with the patient, we encourage them to think about what the patient does on a daily basis and assess their level of adaptive functioning, as we call it. So what can they do on a daily basis? What things do they need help with? Are they independent going out by themselves, using money, that sort of thing? And we also encourage them to use any data available in terms of like IQ scores. If they've had neuropsych testing done, that can be integrated into the assessment as well. So we provide this table to have a rough estimate of where someone's intellectual ability is based on their IQ scores. And then we give them sort of a mental age equivalent so that they can understand developmentally where their language has to be tailored to for these patients. And then the capacity assessment model we teach the learners about, there's a lot of them out there, is this one actually from the critical care literature that's pretty easy to remember. It's called CURVES. So we just remind them to go through a decision-making process with the patient, ensuring that they know how to choose and communicate, they understand the decision, they can reason their choice, and then that there's an assessment of this patient's previous values and how that aligns with this current decision. And then we also talk about emergency situations, like things we might see in the hospital and where that would be more of a surrogate system or a healthcare proxy. And then finally, our transitions of care content for the presentation. We end up talking about transition through a timeline. So we have it span from pediatric to adult life. And we basically start off by just saying transitions of care themselves should be this kind of purposeful and deliberate process rather than something that just happens because it has to. And sometimes that is the case, unfortunately, but we encourage our pediatric residents to start thinking about this for their more complex patients at the age of 12. Because that's when we can really start identifying what barriers there will be later on to making this transition happen. And that can help both the school get the patient and the family ready, any other subspecialists get ready for their transition, and make sure that nothing gets lost in the process. And we also teach them about writing a transition plan. On the pediatric side of the presentation, we have a specific focus on that. And then for guardianship, as we showed you the models for decision-making, we go over how there are multiple choices, not just guardianship, but if it's appropriate for certain people, how they go about applying for it. And then finally, we talk about some of the school services that are available up to age 21. And then after that, how there's the application process for Social Security and that sort of thing. And then to assess the curriculum and see how well it's actually serving our learners, we developed this questionnaire. So to kind of summarize the knowledge content that's covered in this questionnaire, we ask the learners about the definitions of autism and cerebral palsy to see if they were able to remember those. Then we talk about the school services being available up to 21. Transitions of care, we ask what age that process should begin. And then for guardianship, we actually break it out into 3 questions. So the definition of it, how it's established, which would be through the court system, and then finally, how this process is certified, like which providers need to basically approve the patient for it and provide documentation. So here are our demographics for the residents that we were able to reach. So we had a total of 66 residents the first year that this was done. And as you can see, most of them were PGY2s, and most of them were internal medicine residents. And among the pediatric residents, most of them had not yet completed their developmental behavioral peds block, which would be a block where they might learn about some of these things. And also most of them did not have any personal or professional experience working with these patients before. And then when it comes to the knowledge questions we were talking about in the questionnaire, we looked at it at the 4 different time points that we had discussed before. So we do a baseline before the workshop, we do one right after, and then we do 2 follow-ups at 2 months and 6 months later. So when comparing the knowledge changes at these time points, from baseline to immediately after the workshop, we saw significant changes in knowledge to be increased in school services, transitions of care, and then the guardianship certification process. Then when we went to 6 months out, the only area that was still significant was transitions of care. And then we finally just put all of the knowledge areas together into a combined score to see how overall knowledge has changed from both time points. And we did see statistically significant increases in knowledge, both immediately post-workshop from pre-workshop, and then 6 months post from pre-workshop as well. So putting all of this together, we talked about the significant findings from the knowledge questions. And the other important thing to note is that there was no statistically significant difference in the combined knowledge scores based on residency training program, PGY level, or prior experience with people who had developmental disabilities. And we also had multiple people give the workshops, and we didn't see any significant difference in scores based on who was giving the workshop. And we've been doing this for the past 3 years now, so we have made some modifications to the original curriculum. So for pediatrics, we have the interactive cases that are within the workshop focus more on transitions of care. And we combine this into a single session that's a little bit longer now than the internal medicine session. So it ends up being a 2-hour session where the first hour is similar to what we saw from this original workshop, and the second hour is more just role playing with cases that are more advanced. And then for internal medicine residents, we do it where the first year residents will get the exact curriculum that you saw presented. And then the second and third year residents will get more challenging cases as their workshop. So rather than going over all of the definitions and kind of the baseline knowledge, we jump right into clinical cases and we learn things through that model. So the next steps for the curriculum, 2 of them we've actually done already. So we've created the 2-year curriculum we just talked about for the internal medicine residents. And in that, we do get opportunities to role play these complex cases. And it also brings out some challenging cases that learners have seen in their clinical environments, and they're able to incorporate some of those into the role-playing process and ask questions they might have. And finally, we also expanded the curriculum to other learners and faculty. So we've done this in an adapted form for the medical students this past November. And it is a little bit more basic, and it just goes over kind of the content areas, but then there are 2 cases that we do in breakout sessions for the medical students where they can debrief with their groups and their preceptors, and then they're able to reflect and ask any additional questions. And in the future, we want to measure the impact of the curriculum on the actual content areas in the clinical setting. So, for example, on the pediatric side, seeing if our patients are transitioned in a timely manner, if there are assessments starting at age 12 to understand which patients might have difficulty with the transition and how we can help them better. And then on the internal medicine side, making sure that any patient with a developmental disability is assessed for their ability to decision make, and if they need guardianship, that process is started as soon as possible. And the other thing we want to do is develop some sort of app or online resource where our learners can actually navigate the local and national healthcare resources for their patients, because there are a lot out there that we're just not aware of, because it's not something that we do for all of our patients. So the key points from pursuing this project are that teaching learners about the care of adolescents and young adults with intellectual and/or developmental disabilities is a really increasingly important area that's underdeveloped in medical education. And using this workshop that presents basic definitions and structured approach to clinical encounters, interactive clinical cases, and specific issues that are specific to this population as they transition is a simple but effective way to teach the topics to our residents. And based on resident feedback that we've received so far, they do appreciate the opportunity to practice approaching these difficult topics in a safe space with their residents and faculty. So just to close out, I'd like to acknowledge my mentor and program director, Dr. Trulio, Dr. Jaya Chung, who's part of the Developmental Behavioral Peds program here, who I've worked with closely, my co-resident, Dr. Jasmine Blake, who's helped facilitate many of these workshops, and then finally, the Institute for Medical Education for this opportunity. Thank you.